Evaluation of PCOS continued. Discussion, oligomenorrhea, more than 35 days without menstruation. Pregnancy test is first thing. Whenever a woman comes in, and whenever you have from any age from, let's say, 8 to 65, always want to first is think of, if it's in the answer stem, is pregnancy test should probably be the first answer. Whenever there's a woman in the question, female in the question, and for whatever reason in the answer stem is a pregnancy test, think about maybe that should be the first answer that you would use. And think about why it would, try to rule out why it wouldn't be the correct answer. So pregnancy test, prolactin and TSH, premature ovarian insufficiency, anti-Müllerian hormone, which is secreted by immature ovarian follicles. This can be used now instead of using ultrasound. It's going to be low in menopause. PCOS levels are going to be high because lack of follicular atresia and ovarian enlargement. Hyperandrogenism, total testosterone, free testosterone, and DHEA sulfate levels. All right, let's go to a patient. This is a 63-year-old female with COPD. What can we do when we worry about on her clinic visits? So what are we going to do? Now, this is a very vague question, isn't it? So she has COPD, and she's coming into the clinic. This is a very vague question. This is actually an example of a board review question. And this is horrible, right? So what do we worry about in clinic visits? And not having the multiple choice stems makes it harder, right? So COPD, first thing we want to worry about is smoking cessation. Now, we also talked in our pulmonary section is that inhaler usage. Remember, we have to have, remember, about 50% of the patients don't use their inhalers right, so we want to make sure they're using their inhalers right. First, are they using them? Are they using them right? And then are they being followed by the pulmonary team? And then what else do we want to worry about in COPD? Goals of care, okay? Goals of care. What stage is COPD at? If they're at advanced levels, do we want to know, do they want to be intubated? Do they want to have, are they wanting to have full code status? Do they want it to be a DNR? These are important things. If they go into the hospital, do they want to intubate them or not? But in context of words, there's still the discussion of endocrine. What are we thinking about? In COPD, what is one of the treatments they get? And if they've had COPD for life, and I guess this lady is 63 years old and she's had COPD maybe from a young age, she's going to get what? Glucocorticoids, and we have to worry about increased risk of osteoporosis. Isn't that horrible how we've gone through just a patient coming in with COPD and what do we need to worry about in their clinic visits? Well, we talked about smoking cessation, inhaler usage. Have they had a PFT? Are they being followed by a pulmonologist? Because studies show that they'll do better if they are. And then goals of care planning to make sure they're not going to be taken care of the way they don't want to be taken care of. And then the real answer here is going to be osteoporosis because potential aggressive amounts of corticosteroids and COPD. So osteoporosis best diagnosis test is going to be a DEXA scan, which is dual energy X-ray absorptiometry, indicated for all women ages 65 and older, young women with risk factors. What would be the risk factors? Our lady was 62 years older, but she's received a lot of steroids. Remember, osteoporosis is a T-score less than -0.2 with a bone density of 2.5 standard deviation or greater below young mean adult. Also, if history of fragility fracture, falling in a standing height or lower and having a severe fracture. We'll go through these T-scores and all this stuff. Osteopenia, T-score of -1.1 to 2.4. So osteoporosis is going to be the main one. T-score less than 2.5. T-score less than 2.5. Osteopenia, -1 to -2.4. Normal is going to T-score greater than -1. Normal is a T-score greater than -1. Risk factors: age, female gender, tall and thin, family history, early menopause, white race, Asian race, Hispanic race, less likely to be thin, less bone density, smoking history, alcohol abuse, hyperthyroidism, hyperparathyroidism, myeloma, sedentary lifestyle because they're not keeping and maintaining that bone density, history of fracture that for unknown reason or low intensity trauma, meaning that they're not in a car accident, they just walked on they fell over and they had a horrible fracture in a first degree relative. All right, discussion of treatment for osteoporosis: calcium, vitamin D, exercise, cessation of smoking. I implore you to look at, when you look at the answer stems, if it says cessation of smoking, that's probably the right answer. You have to kind of prove that one wrong because it's cheap. It takes care of multiple disease processes. If you can get patients to stop smoking, very important. Oral bisphosphonates, first-line therapy, odendronate, risinonate, ibandronate, IV bisphosphonates. Patients with contraindications or intolerance to oral bisphosphonates, dendroic acid, IV bendronate. For patients with T-score negative 3.5 or below, or T-scores negative 2.5 or below, plus fragility fracture, consider parathyroid analog for 24 months. This is tirzepatide. Dezanizumab is an alternative for those with impaired renal function, cannot be used in patients with hypocalcemia. Duration of therapy should be individualized based on patient characteristics and preferences. There's currently not any great data. Bisphosphonates, actions, potent anti-resorptive agents that reduce the incidence of vertebral and non-vertebral fractures by 50% during the first year of treatment. Now, this is where the controversy is how long to give them for. You need to discontinue after 5 years of use, results in minimal bone loss, because you also can have bone loss with these too. So how long to do them? That's a lot of questions on that. Individualist decision, reduce the number of active remodeling loci on bone surfaces, which leads to decrease in bone fragility. Should be limited to persons with an estimated creatinine clearance of 35 milliliters per minute in a normal vitamin D levels. Hypocalcemia can develop with low vitamin D. Approved for both prophylaxis and treatment of osteoporosis. Bisphosphonates. Side effects. Chemoesophagitis with risk decreased with 1 week preparation. So you need to swallow, so we're taking it once a week instead of daily. Swallow the tablet with a full glass of plain water on an empty stomach first thing in the morning, and they need to remain upright, sitting or standing for at least 30 to 60 minutes prior to consuming any other food, drink, or medication. Osteonecrosis of the jaw. Risk is higher in cancer patients and any compromised patients given IV bisphosphonates. Atypical fractures, see, they can help prevent fractures, but they can have atypical femur fractures after 5 years of use, may be present in the groin or mid-thigh pain. So this would be a good board question right here is, patient has been on a bisphosphonate for 6 years and they present with groin or mid-thigh pain. So if first you would do x-rays, if they're negative, consider getting an MRI, and then consider drug holiday after 5 years of use. That's where it becomes kind of tricky. Agents, odendronate, risinonate, ibandronate, reduces vertebral fractures only. See, it's really important. Reduces vertebral fractures only, but it is important. If you have a fractured spine, life is not going well for you. Verbinderabate can be taken monthly. IV zodendronate is taken yearly and can be used in patients who cannot tolerate oral bisphosphonates. Dezanizumab is a newer anti-resorptive agent. It's a humanized monoclonal antibody directed against the receptor activator of nuclear factor Kb, which is the rank, reduces bone reabsorption by inhibiting development of osteoclasts, approved only for women with postmenopausal osteoporosis and a high risk of fracture, not approved for prevention of osteoporosis. It may have a role in patients who are intolerant or unresponsive to other therapies. In those with impaired renal function, fracture prevention is similar to bisphosphonates. Given subcutaneous Q6 months, no definitive endpoint for cessation. Effects are not sustained when treatment is stopped. Should not be used in patients who are immunosuppressed. Then desmolizumab. Side effects: musculoskeletal pain, hyperlipidemia, increased risk of infections, particularly skin infections, osteocrosis of the jaw or femoral fractures, and atypical femoral fractures, similar to the bisphosphonates, right? Should not be used in patients who are immunosuppressed or have hypokalemia. Because of similar efficacy as bisphosphonates, significant risk factors, profile, and experience, It should not be used for routine treatment of osteoporosis. It's expensive. Rofloxacin is a SERM. It's a selective estrogen receptor modulator, approved by the FDA for both prevention and treatment of osteoporosis. Reduces risk of vertebral fracture by 40%, but does not reduce the risk of non-vertebral fractures. Similar to bisphosphonates, good choice for women whose bone loss is the primary in the spine, unable to tolerate bisphosphonates, or have increased risk of invasive breast cancer. Does not increase the risk of endometrial cancer, reduces risk of invasive breast cancer, may cause hot flashes, leg cramps, peripheral edema, increases risk of thromboembolism. So here could be another question that could be is that the patient, they can even be real vague on what the medication is. They can say that the patient has increased risk of breast cancer, so they were given a medication for their osteoporosis, and they were noted for what? A DVT, okay? This could be one of those things. This could be one of those tertiary level questions. In lipids, they're going to have decrease the cholesterol, LDH decrease, and they have no changes in triglycerides and HDLs. You can't give these to patients who are pregnant or history of thromboembolism because it increases the risk. PTH analog is going to be tirzepatide. It's an anabolic agent that stimulates osteoblastic bone formation, increases bone mass 8 to 10% per year for up to 2 years, reduces risk of vertebral and non-vertebral fractures by 50%. Should be limited to patients with moderate to severe osteoporosis and those with increased risk of fractures or previous osteoporotic fractures. Max use is 2 years. Combination therapy with bisphosphonates increase bone mass less than PTH hold. A bisphosphonate should be started after completing 2 years of tirzepatide therapy, or some or all of the bone gained will be lost. Okay, it does have a black box warning for osteosarcoma, increased risk of osteosarcoma. Man, none of these medications are great. When you look at all these things that they can do, and then, yes, it's very important and need to be taken, but these medications have serious side effects. Osteoporosis in men, hypogonadism, and what would be examples where men would get osteoporosis? Hypogonadism, Klinefelter syndrome, or cryptorchidism. Androgen deprivation therapy, lipoperidide, and surgical orchidectomy. This would be in connection with what? With prostate cancer. Osteoporotic skeletal fractures occurring in 20% of men within 5 years of administering these medications or having a surgical, they're having their gonads removed. Acquired hypogonadism in mumps, cirrhosis, CKD, and HIV. Hyperparathyroidism. These are examples of conditions that can cause osteoporosis in men because it's less likely in men. Here it is at glucocorticoids, this patient who has COPD and on anticonvulsants too. Celiac disease because you're going to have impaired vitamin D, decreased vitamin D levels, and you're going to have impaired absorption of calcium and inflammatory bowel disease, and vitamin D deficiency, tobacco or alcohol use. All right, we have a 57-year-old male who gets an abdominal scan for pain. What? So what does this have to do with endocrine? Did you know that at least 20 to 40% of all CT examinations contain at least one incidental finding? And we're going to talk about adrenal insulindomas. Okay, these are lesions reported in 4 to 7% of all abdominal scans. Think of all the abdominal scans that are done in the U.S. And I was trying to get the statistics on this, but there's very hard to get specifically how many abdominal scans in the United States. In 4 to 7% of them, there's millions of these scans. Studies have shown detection rates as high as 12% in some cohorts. So up to 12%, say 10% of abdominal CT scans, you're going to get adrenal insulindomas, okay? All right, more discussion on adrenal insulindomas. Remember, we're getting more scans, so you're seeing more of these. And what should you do? Should you just ignore it? No, remember, first do no harm. We've talked about this multiple times in the lecture. You ordered a scan, and you have to be forthcoming with the patient and show them, hey, this is what popped up. This is probably going to be nothing, but we should work through this and have a discussion with the patient so they're aware. You need to complete an overnight dexamethasone suppression test if you're noted for these. Also check urinary catecholamines and metanephrines. If hypertensive, check aldosterone to renin ratio. If excessive hormones noted on labs, consider surgery. The association of mortality and cortisol increase linearly until the cortisol reaches 200. So meaning that the higher cortisol levels are increased risk of mortality. That's very important. Very important. Now, if everything is negative, you need to consider malignancy. And when would you consider when the adrenal gland would have malignancy? Now, these are things that the radiologist will help you with. When it's greater than 10 Hounsfield units, the mass is greater than 4 centimeters. And then if there's greater than 50% contrast retention 10 minutes after contrast administration, these are all things that would be noted on the report, so you'd have to consider, is this a potential malignancy? More discussion on adrenal insulinomas when they're dense, vascular with irregular borders. This is when we're concerned for malignancy. As we just discussed, we're going to keep hitting this because this is important. Concern for over 4 centimeters need to be removed. If not over 4 centimeters, repeat every 4 to 6 months for 2 years. All right, this is another one. Is a 63-year-old female complains of chest pain and gets a PE study. Well, guess what is noted on this? They may go and catch the thyroid, right? Now, how many PE studies are done in the US? I couldn't find that exact information, but incidental thyroid nodules are seen in 8 to 25% of patients. Between 15 and about 5 and 15% of thyroid nodules are malignant. So insulin thyroid nodules are seen on imaging in 8 to 25% of patients. We know there's a lot of imaging done in the US. And of these nodules, 5 to 15% of these thyroid nodules are malignant. So important. The characteristics for malignancy: rapid growth, fixed hard cervical lymphadenopathy, hoarseness, dysphagia, ultrasound size greater than 1 centimeter, microcalcifications noted on imaging, hypoechoic, increased vascularity. Remember, cancer wants blood. They want to suck our blood, suck our nutrition, infiltrated margins, and length greater than width. So let's discuss thyroid nodule management. You want to measure the TSH. This is a great board question. What is the first thing you would do is measure the TSH. If it's normal or high TSH, you want to get a thyroid ultrasound and select nodule for fine needle aspiration. Benign, have serial follow-up. Malignant or suspicious for follicular neoplasm, get a surgery. Low TSH, so we get the TSH is low. Get an uptake scan, radioactive uptake iodine scan. If it's cold ultrasound and fine needle aspiration. Remember, it's hot, get radioactive iodine or surgery. More discussion on fine needle aspiration. Do not stick a needle in something hot. This is simple. So this is for boards, and this is for real world. You're not going to do a needle biopsy in something that's hot. Remember, just think about that needle, putting a needle in a hot biopsy. You don't want to do that. You're not going to do a needle in something hot. Cystic nodules do not require fine needle aspiration. Benign. High-risk patient, consider for any size in the below group. First degree relative of thyroid cancer, makes sense. Radiation exposure in childhood. Radiation, when would that be? Maybe they were treated with a lymphoma. They had radiation exposure. Rapid nodule growth. Cervical lymphadenopathy, the body's reacting. Let's discuss low-risk nodules. Isoechoic, meaning the same echogenicity as the other tissue. Hypoechoic, more echogenicity, brighter than normal. Partial cystic, FNA greater than equal to the fine needle aspiration if greater than equal to 1.5 centimeters. High-risk findings, FME nodules greater than equal to 1 centimeter if microcalcifications, increased vascularity, hyperechoic, meaning the tissues are more dense or more solid than usual, indistinct or irregular nodule margins. Risk factors for malignant thyroid nodules: exposure to ionized radiation. We talked about this. Family history of thyroid cancer and family history of MEN2s, which medullary thyroid cancer can be prominent. Iodine deficiency and increased TSH associated with increased risk of malignancy in a thyroid nodule. Let's go through this algorithm. Evaluation of thyroid nodule. First, you always want to get the TSH. If it's low, get a thyroid scan. In a hyperfunctioning, we have to worry about a toxic adenoma. You would measure the free T4 and T3 if elevated. History of hyperthyroidism and get checked for radioactive iodine. All right, so if it's normal or high, you want to get an ultrasound guided fine needle biopsy. All right, suspicious for follicular neoplasm, get surgery and removal. Non-diagnostic, you're going to repeat the fine needle biopsy, ultrasound biopsy. Benign, repeat ultrasound in 1 to 2 years or 6 to 12 months with suspicious features. If 50%, greater 50% change of volume or greater than 20% increase in 2 nodule dimensions, repeat fine needle aspiration. If malignant or suspicion for malignancy, surgery. All right, let's go with an unfair board question. We're going to go with the question stem first. What is the most appropriate next step in management? Observation with periodic clinical and ultrasound follow-up. Levothyroxine suppression therapy, radioactive iodine ablation, total thyroidectomy, external beam radiation therapy. This is a 55-year-old woman with slowly enlarging anterior neck mass. She reports mild dysphagia but denies pain, hoarseness, or dysphagia. Dyspnea. Physical examination reveals a firm, non-tender multilobular nodule enlargement without cervical lymphadenopathy. Laboratory studies show a normal TSH. Thyroid ultrasound demonstrates multiple nodules, with the largest measuring 2.5 centimeters with no suspicious sonographic features. Fine needle biopsy aspiration of the dominant nodule is benign. What is the next appropriate step? Okay, it's going to be observation with periodic clinical and ultrasound follow-up. In patients with non-toxic multinodular goiter who are asymptomatic. So in this question, she has mild dysphagia, but if it gets worse, then you'd have to consider surgery. Multinodular goiter. So we want to consider is if the TSH is normal and the free T4 is normal, we're going to just observe. If the TSH is low and the free T4 is elevated, radioactive iodine to ablate this. If the TSH is low and the free T4 is normal, if they're asymptomatic, you observe. If they're symptomatic, radioactive iodine. All right, so needle biopsy of individual nodules greater than 1 centimeter or nodules that seem to grow disproportionately to other nodules or have concerning ultrasound features. Patients with multinodular goiter may develop thyrotoxicosis on exposure to iodine-containing contrast agents. Where also can this be seen is medications or over-the-counter supplements. Over-the-counter supplements such as seaweed or kelp have high doses of iodine. What's another one is amiodarone has high doses of iodine. And that's it. That concludes endocrine, and we'll get on ready for our next section.